Hello and welcome to another episode of Onc Now with me, your host, Dr. Jonathan Sakia, where each week we delve into innovations to enhance healthcare quality. Today, I'm thrilled to welcome Dr. Aniket Mohite, consultant haematologist-oncologist and an esteemed member of our editorial board for EMJ Oncology. Aniket has over a decade of experience in the field and has trained at leading medical institutions and hospitals across India. He completed his medical degrees from GS Medical College and King Edward Memorial Hospital, Chem Hospital, and MD in Medicine from the prestigious Lokmanya Tilak Municipal Medical College in India. Aniket is deeply involved in patient care and has been instrumental in leading several medical initiatives in his community. His dedication to improving healthcare accessibility has seen him actively involved in various health camps and community outreach programs, particularly in rural areas where medical services are scarce. Aniket has an extensive record of participation and recognition in hematology, oncology, and related fields. His work, particularly in haemophilia care and graft-versus-host disease, has been showcased through poster presentations and papers at various conferences like Hematocon and the Diamond Jubilee celebration of the National Institute of Immunohematology. I hope you enjoy our conversation as much as I did. So with that, over to Aniket.
So, real delight to have you with us today, Dr. Aniket Mohite. It's an honor to have you here.
Thank you, Jonathan. It's a pleasure being a part of this podcast.
Fantastic. Well, let's leap into it. So, haematology-oncology is a very specialized field. What inspired you to take that path, and what drives your passion for working in this demanding but rewarding specialty? And you did say when we were chatting that we were talking about other podcasts that you listen to, other than the EMJ series of podcasts, and you were saying that doing oncology can be quite depressing. Because you're dealing with, seriously ill people. So tell us about your journey and what's rewarding as well as demanding.
So right from my undergraduate days, looking at where in physiology you have to look at your own blood film, prick yourself. It gives you the pain that the patient goes through. So looking at those blood films in the undergraduate, in the first and the second years as a pathologist during the pathology or in the physiology classes, to get to look at your own body better and try to understand before you try dealing with the patients in medicine. Now, once I finished my undergrad and was going to get into the medicine, the specialties around which I saw were all nephro, cardio, and there was a lot of lacking in India, like even currently in the city which I am. Currently, we have just 6 or 8 of us. So in the state, we were just having 2 seats or 2 candidates per year. So it's quite a challenge to get into this course. Plus, there's a lot of lacunae of people around. So there are a lot of unmet needs that there were very few people who were able to get into the course. And the challenge was to pursue this because it is a combination of pathology as well as medicine. So from the undergrad times, I had a gist of getting into research, knowing new things, and hematology is an ever-growing branch of research where you have a lot of genes, you have a lot of genetic problems, and getting to understand better, like a simplistic thing which is common, like anemia, where around 70 to 80% of Indians would be having a low hemoglobin to begin with, which could be measured at times nutritional. But getting just blood transfusion was the main modality in many of them, getting to the root cause and giving them a best possible diagnosis and prognosticate them further. As well as a team, or as a part of the team, I was able to help to all the other specialties, be it obstetrics, where they were dealing with life and death of a mother and a child who was in DIC or in postpartum hemorrhage or RH incompatibility. So the smaller issues which I went through during the medicine course dragged me into the hematology. Along with this, some pioneers like Dr. M.B. Agarwal, who was there in Mumbai, where I did all my hematology training as well as my graduate training, and Dr. Navin Khatri, who was there in Tata Medical Center or Tata Memorial Hospital, which is the biggest oncology hospital in India. So looking at such stalwarts gave me more of uh, a, and a driving force to get into and help more and more people, where we saw people lying in big rows where in the numbers of hundreds or 150s. So with increasing task force, that could help and provide better quality of care to the number of people that we have.
So, Aniket, thank you very much for that. You've worked in various hospitals in India, internationally. You've seen different spectrums of disease, different attitudes to treatment, different medical systems. How do you think your experience, or even your experience, it's easy for me to say, how do you think your experience abroad has shaped your approach to patient care where you practice in India?
I mean, definitely, I feel lucky enough to go abroad and have training in the best institutes in and around the world. So when I finished my DM for the hematology, during the course, because like what I just said, during the course, we were seeing around 100 to 150 outpatient patients, and we were having the wards completely full. So the amount of time that we could cater to or give justice to each patient or to the families was very limited. So, more so, we were limited to just write down prescriptions, write down the plans of treatment, explain them whatever way we can in the smallest amount of time that we have to go to the next patient. Now, when I went to Tata Memorial, which is another cancer institute in India, there the volume was more, but it was a better organized institute than what I learned in my DM graduates. And further moving to Canada, there I could understand the importance of team. So these two institutes have guided or made me into a consultant what I am now. So the one is the amount of discipline that you get into when you get into the practice, that uh, you spend enough time. The It is more of a listening ear that is important, that to understand what are the problems that the patient is going through and try to uh, get to or find out the best possible solutions to all the problems. Now the problems could be very big enough from that extent, but you can give simple solutions, like for examples, uh, in India, where I was seeing n number of patients. When I went to Canada, I was seeing just 5 or 6. So initially, I was like, "What am I going to do with just 6 patients in a day?" But when I started working in there, I found why am I only seeing 5 or 6 patients in the outpatient consults, or why I'm just seeing 6 patients in the inpatient transplant units. Now, I was able to give more justice to their needs. I was able to pinpoint what exactly are the problems, what exactly were the problems during transplant, what chemotherapy would be best suiting them, what medications would be best suiting them, if there are any allergies were picked up earlier than dealing with later. The smallest nooks and cracks of giving patient care were better evident to me, and I could, with broad open eyes, I could see them, that these were the fallacies which were lacking in my training before, or if I would have just started my practice post my DM as a fresher into a consultant, I would have not got into this. Two, uh, the upfront practice of discussion into as a team. Like here, we were more so of a one-man army, like one person doing everything possible, giving chemotherapies, planning the treatments. You might be lucky to have nurse practitioners to guide you to them. But when I went to the West, we were having rounds for 1 to 2 hours, where it was a dietitian, it was a team of physiotherapy, it was a team of nursing lead, it was a team of consultants, which were again 3, 4 of them, and physician assistants. So it was inputs coming from each and every one, which would be different angles and giving a good or a holistic patient care, where looking from only from the treatment or physician angle, I think was a missing link. Just looking from horse eye angle, like we were just restricted to treatment, side effects, and just get away with the treatment without much problems. But looking at the whole team approach, when I came back and started my practice, that is something which I have built up. So I have a team of ID specialists. I have a team of a microbiologist who gives me inputs of what are the cultures as quick as possible. The pathology team, which gives me inputs of what is the disease, what is the bone marrow showing. Even I go and have a look in the microscopes as I do. I'm done with the marrows. So it is a whole team that has been built with the nurse practitioners around, dietitians around. So the same ethos which I saw there, where it is working so beautifully, I am I'm restricted to maybe a 10 or 12 patients. I cannot restrict it to 5 or 6 patients in India. We cannot have that much privilege because we have to cater to a number of patients with the population load here. So
Sure. Sure.
the outpatients are at least restricted. The inpatients, we have a team which so that helps us to visualize each and smaller nooks and corners of the patient treatment, improvise their care, reduce the number of infections, because infection burden compared to the West, that is something which is a challenge which we face in India. So having that also tackled, so that was from the TMH training which I clubbed in as to what is the Indian standard that I can join up to what was the West. And along with this, a consult about fertility, because the oncology patients in hematology live long. So once they have their whole life, the future generation is also preserved. So that gives them another gist that, well, you are living longer out of the disease, but you can still have your next generation not having the disease passed on, but you can see your children's growing with your own eyes. So the depression
Yeah.
or the problems that the later life problems which could be there, like at the outset itself, giving them to the fertility consult. Fortunately, my wife herself is an IVF specialist in my institute, so that gives me much ease up to send it to her and get the fertility consult done, and we can discuss amongst ourselves as to when is the chemo plan and how we can go ahead and give
Yeah.
them a good quality of life out of cancer, and give a good quality family life later on in life as well.
So you've effectively got an all-point solution within the family. Thank you for that. I've had the pleasure of visiting India on a number of occasions, and the last time I was there was at the Medanta hospital, and I was blown away when I was getting a tour, and they were telling me how many of this procedure, that procedure, and the other procedure they do. And for people who haven't traveled in our profession, I encourage them to, because I've said this before on this podcast, another podcast, that anytime I've gone to teach overseas, I've always learned much more than I've taught. And certainly was the case when I was visiting your country. So, Aniket, you've presented your research at numerous prestigious conferences. Can you share one particularly memorable experience or finding that you think had a significant impact on you and on your field?
Among the two conspicuous research papers which I had gone to present was one when I was in Vancouver, I'd gone to the Florida for the ASTCT, that is for the American Stem Cell Transplant meeting. And the another was the European Bone Marrow Transplant, where I'd gone to present from TMH about a drug called leflunomide, which is used in a lot of rheumatoid arthritis patients. But we tried using that in chronic GVHD, which again presents more so like a lot of arthritic problems. When I went there, what in 2018, before going to Canada, what was shocking or just was eye opener to me, what the amount of research which was going on in the West was way ahead than what we were doing in India at that point of time, where there were papers that were presenting about cellular therapies. There were a lot of research which was going on to of immunotherapies and targeted treatments which were going on, which were nowhere they were being touched to if we had to use that after reading a lot of articles around which were presented in the world after that when I gone through. Those were all eye openers that transplant was not the way forward, was not the only curative way forward. There's a lot of science which is coming up, and we are still learning more and more ways and modalities of giving the best possible cure care to the patient with least toxicities and targeting more so to only to the cancer specific treatment and less affecting the body. Like transplant is quite complicated, is quite toxic, it's quite morbid to the patient as well as to the family, financially as well as emotionally, physically. So with these advents of targeted treatments, though at the initial juncture they would be costlier, but gradually they would turn down to become a quite better modalities of treatment. So down the lines now, I'm quite eased out after going to Canada, where I had a hands-on experience on CAR T cells therapies while I was being there, and now in India, I have CAR T enrolled in my center as well. So it gives me a sense of relief that science, which if I would not have been exposed to those meetings, I would have been shaken away now when these were launched in India. Now we have the indigenous CAR T in India. So the pleasure or the ease of using that or advocating it to any of my clients or any of my patients, those, if I would have missed those meetings, I would not have dared to prescribe that to any of my patients, because that I would have been shaken off. I have not used this science before, so whether how will that act, whether that will benefit, whether I'll be able to manage those effects, side effects. But yeah, I mean, with all those advances now, I'm quite well versed with what is there and what is coming in future, and we are in close connect with all the Canadian faculties as well. So what's the research going on ahead? So that is able to grab me a step ahead than what is going to be the near future.
Yeah, it's lovely. It's a lovely element of international collaboration and the friendships that we build as physicians with each other across the globe. So your specialty has changed dramatically, certainly in my lifetime, dramatically. And there've been a lot of advances, but with positives, there's always negatives. What are the biggest challenges facing hematologist-oncologists today, and what strategies do you believe are essential for overcoming those challenges, or at least managing them? And I'm sure that you're going to say cost is one of them.
Yeah, so definitely I'm going to. So cost is one of a bigger challenge, especially in a country like India, where we deal people coming from different strata of economic groups, where majority of them would be into lower or middle socioeconomic areas, where cost becomes a quite significant deciding factor. But in still with a lot of research going on in India, uh, indigenous research as well as foreign collaborators that we are now being able to get into trials, it has become a bit easier. But the numerous other problems that what we would be facing in India is infection burden. Now, I was quite taken aback when I went to Canada. I was just walking into the transplant unit, but when I devise a transplant unit here, I have to take every step that I change my clothes, I used it autoclave. So the amount of infection risk that we face here, the amount of XDR, MDR, XDR organisms, tuberculosis has always been there, with a lot of gram negatives, which are XDRs, and not much drugs in the armamentarium that we can use. A lot of patients have infection related mortality. So salvaging a lot of patients or giving them cure, many of them around 20 to 30% would lose. We would lose them either to CMV or EBV reactivations or to bad gram negative sepsis. So with all possible efforts, we are not able to save quite a significant proportion of our patient load. Apart from finances, infection is one burden. The another problem which I face, and especially in transplant, like in the West, when you don't find a family donor, you go to the registry and you just do a registry search and can easily find a mud donor. And many of my even the retired faculty members were doing the job of transporting or transferring stem cells from one country to another when some of the patients were getting stem cells from Australia or from even China for that matter, because of the Chinese origin living there. But in India, sadly, despite a lot of populations, we have very few unrelated donor registries with only around a few lakhs of donors which are willing to be as a part of the donor registry. So there is a lot of challenge where we have to go down to haplotransplants, which is a bit more toll on the cost as well as infection burden, GVHD. Again, a lot of complications coming on with it. So uh, getting a right donor when there is no sibling is another challenge when we go on to transplant. So apart from finances and infections, getting a right donor in transplant is where the whole process of transplant starts on with. Sometimes it becomes very difficult where a lot of people still have consanguineous marriages. So a family sibling may not be used for thalassemia or immunodeficiency patients. So it becomes difficult in those scenarios.
Yeah, that's interesting. Yeah, we're seeing, aren't we, more and more the impact of antibiotic resistance and the need for good antibiotic stewardship as infection becomes more and more an issue. We're hearing more and more about it from every specialty. So patient education empowerment are crucial in managing chronic conditions like cancer, blood disorders. So how do you approach educating your patients and their families, especially in settings where medical knowledge might be limited? How do you view the way social media is deployed and the way patients and their loved ones use the internet to search for medical information? It's politically incorrect nowadays to acknowledge national and cultural differences, but I think personally it's asinine. I practiced in the United States and the United Kingdom, and I've traveled extensively, and I've seen it. People are different, right? And they have different expectations and different educational levels and different cultural imperatives. So patient empowerment, have at it. What are your thoughts? Patient education and empowerment.
Uh, there's a lot of lacunae about patient educations, especially with a lot of still different education background that patient comes from, whether it is from the rural or whether it's come from the urban or the semi-urban types. Uh, with the advent of a lot of technology advances and the easy availability to telephones and internets in India, people are now having Google searches or getting into the social media at least platforms and searching about. So any client who comes to me would have at least gone through my LinkedIn profile, seen what I have done through what are would have gone to my YouTube or to the other platforms. Like the way we discussed in the initial part, that I listen to podcast, I do my own podcast as well. So I use different social media aspects to uh, meet or give them pictorial images to make easy information brochures. So whenever I counsel or see any patient, this is again something which I saw in Vancouver, where a moment a patient is diagnosed, they are handed over. Like I am told that I have to undergo an allogenic stem cell transplant. You hand over a brochure to them or a booklet about them. It's not a brochure, would be an incorrect name. A booklet as to what is the info about what is uh, bone marrow transplant, how do you find a donor, what is transplant, and what are the myths and facts about it. So a similar model is what I have worked into my practice as well. I've written books in local languages or in easy to use fonts where it is available on my website as well as we give it distribute as a soft copies. I've made utilization of social media of YouTube as a major chunk, along with Spotify and other uh, social media aspects, where I try to educate them as to different aspects about it's not just for the patient, but it's also for awareness about physicians, pediatricians, gynec. So I try to educate our own peers and colleagues also through webinars and through meetings, into social gatherings or online. With the post-COVID, the advent or access to online has become now universal. So, along with this, along with just not for the patient, I try to educate our own colleagues as well. Where there's what I feel there's quite. Uh, I was a bit astonished with a few of my own senior colleagues asking me as to what are the indications of transplant and what do you do in transplant? Is there a surgery? So this is something which even a layperson asks me whether there is a surgery involved in transplant, where transplant is bone marrow transplant is unlike any other solid organ transplant where there's no surgeon involved. Uh, so what I feel is there are lots of unmet needs, or there's a lot of misinformation or no information at all about the field of hematology. So I try to make a small videos or small maybe images or cartoons about it and try to share it into the social media aspect. I have a digital team as well to help me along with that so that we can spread the information in a way that can be easily accessible to, it can be easily understood by a layperson as well. So we have made different sections to it for medicos as well as for non-medicos.
Yeah, it's. I'm glad to hear you say that, because the issue is there's so much information out there, and I like to say, a colleague of mine taught me the expression that Dr. Google doesn't have a medical degree, and if we as physicians take the responsibility to create content that is non-promotional, that's accurate, that's delivered in a caring and non-condescending way, and for the benefit of people listening who have not traveled to your country. Number one, it's a massive country with a massive population. And I can't remember exactly how many indigenous languages there are. I know it's over 20.
28.
Do you?
28.
28. Okay.
So
I
that
mean,
is
I'm
just
thinking
for
when I.
the superficial state-wise, but within the state, like I live in Maharashtra, where in Maharashtra itself we have different dialects on the east of Maharashtra, on the west,
Yes.
north, south. So the dialects also differ. So we have to kind of make it easily accessible and understanding
Yeah.
compared to the different.
But that's a challenge. When I know when I was practicing in California, and the fact that everything was in Spanish as well as in English, and nowadays with multiculturalism, you've got these challenges everywhere. But you've got indigenous populations with multiple different languages, a huge challenge. Anyway, there's something I want to dig into. I saw an article from the Hindustani Times on World Cancer Day. And I'm going to read this. It's, let's join hands to make people more aware and support those bravely dealing with cancer. It's a day to speak up, show understanding to patients and their families, and give them hope. In this article, health experts share their thoughts on World Cancer Day, talking about how they're working together to make cancer care better and provide essential support. The aim is to bring more understanding, resilience, and optimism to individuals and families facing the challenges of cancer. Together, we can create a supportive community and spread hope on this important day. Talk to us a little bit about initiatives like this, please.
Okay. So the reason why this initiative was taken is Hindustan Time has fortunately quite uh, uh, coverage to every part of India. So the access or the information would be shared to many. Two, the word cancer, many people still think that their life is now shortened down to a few days or a few months, and they start counting days as to they would just survive for a few time and try to just restrict themselves to their family and peers. They don't even come or to the amount of stigma which was still there, that with chemotherapy you will have hair loss, you will have so many complications. So they have just overheard about the complications from the past generations, and with the advances which have come in science and the advances in the technology for diagnosis as well, which were not there maybe 3 decades back. So where now we are able to go to the lowest possible gene, try to find out what is the trigger zone, and where we can just hit the cancer and not hit or affect a minimum effect on the body of the patient itself. So where we are trying to do more so from a generalistic cancer therapy to more of a individualized and more targeted treatment guidelines. So this is something which we need to spread a word or sensitize the community that look, you can still live a normal life as like any person. The way HIV was in the initial periods where it was considered to be dreadful, people were dying in few months, and now it is more like any non-communicable chronic disease. So similar way, cancer is also becoming more like that, and you can live a lifespan of at least 10, 15 years, if not more, if you are in the ages of 50s, where you can at least live till your 60s or 70s and not immediately would be dying in a few months' time. So this was a way to just generate an awareness about that cancer is not a dreadful word anymore. You have ways and modalities to get you back to your normalcy, get you back to your work if you are young and working, that you have still life ahead and you can still fulfill the needs of your family. Maybe you may just have to take a few months break from your work and get back to work after you get better.
Interesting that, again, certainly in my professional lifetime, you look at pediatric malignancies, and it's been a game changer, a total game changer. So smoking is a well-known etiology for cancer, yet it's still quite common, especially in India. What more can we do to limit tobacco use? They're trying very hard over here to move towards a total ban. What other causes of cancer can we address? There's obviously been HPV out there as well for cervical and throat head and neck cancers. What are the others? And what can we do to cut down smoking?
There's no ban so far in smoking in India. There are smoking zones that they have created in every airports, every restaurants, where the smoking is still going on in ample manners, even in the public places. But people are moving towards maybe something which is not that much harming. They're going towards nicotine gummies. They're going towards with the knowledge about more and more about smoking, the amount of burden of smoking has reduced a bit, but there's still a lot of population who is used to betel nut or what we call the local gummies kind of thing that they use, which has been a challenge. That is what the gutka is, the local name that we call it. So that has been having a lot of oral cancer. So oral cancer has been a leading type of cancer in India, which is all related to these habits of tobacco chewing rather than smoking. But with more and more literature about it, people are now going to nicotine gums or nicotine sprays or to the patches where the exposure to the nicotine has slightly reduced, but it is still a major challenge uh, at the at multiple areas or multiple places in India. Two, HPV, as you rightly said, is still cervical cancer is the leading cause of cancer in females. So oral cancer is the leading male, is the most commonest cancer in India, followed by cervical cancer in females. So HPV vaccines have now been an advent, and there is a drive nationwide from physicians, from pediatricians. Like I deal with pediatric till the elderly age group. So we it ideally has to be given in the school going age itself. So we go and address to the principals all to the schools that look, we need to vaccinate them just before they start into the sexual exposures, and those who are still in have not got or not didn't get the vaccine and still are sexually active and are HPV negative, we are extending that to the adults with our cancers as well, so that they don't end up getting a cervical cancer down the line. So we are trying to immunize as much population as we can. The way we are giving herpes vaccines, pneumococcal vaccines to our chemotherapy patients, we are extending the HPV vaccines to a lot of our community, and there's a community drive going on in India through a lot of film stars as well, going around and educating people. So it is to try to prevent at least. It is the only cancer which can be vaccine preventable that has been proven. So there's a lot of drive to bring down cervical cancer in India. One thing which I would also address about is a lot of radiologists or cardiologists who are continuously under the cath labs or in the C arms. What we have seen is a lot of hematological malignancies because of radiation exposures of either the long times happening in them. I have one of my professors of my teaching institutes having CML, who was a cardiologist and developing CML possibly related to the radiation exposure. We can't definitely say that the radiation is one of the cause of it. So there's a lot of radiation exposure to the technicians, to the radiologists doing their work in and around there. And that is something which can be preventable by reducing the hours or restricting the monitoring the TDM values of the radiological multiple junctures.
Sure, sure. So a little bit earlier, you talked about some of the advances in CAR-T and such like that you've been exposed to. To further develop that theme, what research, diagnostic, or therapeutic are at or just over the horizon that have you excited about the impact they can make in oncology?
Now, the research that has been made just recently, I mean, there's been a lot of work going on for the last decade for gene therapy. Now, CRISPR for sickle cell disease was just launched this year in the last 6 months or so. So this is something which gene therapy has been tried for hemophilia, for thalassemia, but this was the first approved modality of treatment. And since hematology has a lot of genetics in it, like if we have more and more advances coming into gene therapy, we would be able to give, because so far transplant is the only way out for such patients. The gene therapy is what it's exciting to me. To a lot of the non-cancerous patients would benefit from it. Coming down to cancer, CAR-T is one, but beyond CAR-T, there are a lot of BiTE cells or multiple targeted single antibody, which is can target 2 or 3 antigens on the same cancer tissue, which was initially tried in ALL and now is getting to AML and ALL and Hodgkin's and non-Hodgkin's, which have been they were transplant was the only treatment options for them. So with the newer molecules coming in and newer and newer advances in the gene therapies and the advances of next gen sequencing available, we are able to go to the lowest possible gene study. There's a lot unknown about why these things happen, but the science is still progressing, and this is something where if you can find and change a gene of some patient, which maybe by CRISPR or maybe of these by the gene therapies coming into cancer, coming into HIV. This can make a lot of HIV-related lymphoma burdens, which are quite difficult to treat, or many of such diseases, bringing that down to lower levels. So that could bring the burden to a very minimum if this treatments become available to a lot.
Fantastic. Exciting times to be an oncologist and to be able to offer your patients that. So finally, a question I like to ask everyone, that if a magical genie came along and offered you 3 wishes in the field of hematology, Hemato-Oncology, what would Dr. Aniket Mohite's wishes be?
I wish I had a genie. So
you've got a genie. You've now got 3 wishes with your genie.
I mean, no, because there's so many unmet needs. I mean, every client, a lot of patients have this question to me, like, look, doc, I am non-smoker. I am a non-addict. I have been all through my life following all the religious rituals, and so far I've been not doing anything wrong in my life. And then why did I get cancer? So there's a lot of unknown things that we still have in oncology, that though hematology has been quite advanced in the genetics per se compared to many other cancers, but there's a lot not ununderstood. And though we have advances in the NGS, there's not much of treatment options that we can offer to every gene abnormality that we look into. So one thing which I would wish to is one, getting to a causal diagnosis to as many diseases of oncology and hematology where genetics plays a role. Even like thalassemia, where we at least know that this is passed on from father to the next generation, and both the parents to the next generation. But still, you have sporadic cases of hemophilia, sporadic cases of the many of these abnormal bone marrow failure problems where there is nothing in the family. So these advances where we can get or give them a good possible diagnosis and treatment to each and every individual would be the first wish. The second is again obviously would be having financial affordability, that every treatment that has come into, or everything which comes to the research, from the books to the practice, should be we should able to be offered to the patient at something which they can afford to, and should be an affordable treatment option. Three, what I would wish to that every individual should have an exposure of all the different ways and different means of, or the modalities of practice worldwide. The way I was able to go to national best of the national institutes and to best of the international institutes, have a knowledge and knowledge sharing going on for all these years together, helps me build a better way and better modalities of treatment. So each and every person at some point of life should become a part of the research. I mean, I'd gone to just extend this. I'm glad to have an opportunity to go back to the research protocol training, which I had done in 2018. Now I'm so much into research that I still want to again get retrained up to what in the last 6 years I've been the advances in research. I'm again going back to the training program of Accord, where I'm still a student. Like the life of in as a physician or as a medico, it never ends. You just have to keep learning, and try to learn from whomsoever and whatsoever you can, and try to get hang on from your own peers as well as nationally as well as internationally. So that everybody should be able to get an access to such kind of care is what I would be wishing, so that we can help each other to serve better at every place where we are.
Well, I think that this conversation has certainly educated me. Another of my friends has an expression: I like to go to bed a little bit less dumb every night. And you've certainly helped me achieve that goal. I'm afraid that that's all we have time for today, to get a sneak peek, if you will, into the world of Dr. Aniket Mohite. And I'd like to thank you, Aniket, for being with us today, for all you're doing for your patients and for cancer generally. It was a real pleasure and an honor to chat with you.
That's my pleasure. And thank you. Have a great day.
So, folks, thanks for listening to this episode of Onc Now. If you've enjoyed listening, and I suppose if you're watching this, you must have, please subscribe on Spotify or Apple Podcasts or wherever you get your podcasts so that you never miss an episode. And check out the archives. There's going to be lots of great episodes there. Until next time, I'm Jonathan Sakia. I thank you for listening. Please, everyone, stay safe, stay well, stay curious. Bye for now.